This presentation is about analgesia and sedation in the critically ill. ICU sedation is a complex clinical problem. Current therapeutic approaches all have potential adverse side effects. Why do ICU people need sedation? It's for anxiety, pain, mechanical ventilation, for treatment or diagnostic procedures, or to remove the physiological response to stress. What are the goals of sedation in the ICU? First, to provide patient comfort. 2, to control the pain. 3, to relieve the anxiety and to provide amnesia. 4, to facilitate nursing management. To facilitate mechanical ventilation and to reduce oxygen consumption. What are the characteristics of an ideal sedative agent? 1, it lacks respiratory depression. 2, it provides analgesia, especially in surgical patients. 3, it has rapid onset, it's titrable, and it has a short elimination half-life. 4, it's an anxiolytic. And 5, it doesn't cause hypotension, so it provides hemodynamic stability. What are the challenges of ICU sedation? 1 is to assess the level of sedation. 2, the ICU patients have altered pharmacology. 3, they develop tolerance. They can also have delayed emergence and have withdrawal when the medication is stopped. And 4, also these drugs can interact with other drugs that are administered to ICU patients. It is very important to provide a net balance between the causes of agitation and the sedatives. If a patient is undersedated, he will be agitated and anxious, sometimes in pain. He's at risk of having any type of catheter to be displaced. His ventilation might be hard. He might develop systemic signs like hypertension, tachycardia, arrhythmias, and he can have any injury. He can self-extubate. On the opposite side, if a patient is oversedated, he might have prolonged sedation, delayed emergence, respiratory depression, bradycardia, muscle atrophy, pressure injury, and this comes at an increased cost to the hospital. The main treatment goal is to provide sedation and analgesia without oversedating the patient. Pain should always be assessed separately. How to assess the pain in the patient, especially in the ICU. Visual pain scales are a bit difficult to use, mainly because a lot of those patients are actually sedated or ventilated or had a previous stroke, so it's very hard to assess the pain visually. What are the signs? The main signs that you can see are hypertension, tachycardia, lacrimation, sweating, and sometimes even papillary dilation. The main principles of pain management. 1 should anticipate the pain and recognize it. When the pain is recognized, it should be quantified and treated, and when it's treated with the appropriate pharmacologic agent, the pain should be reassessed to see if our intervention worked or not. Non-pharmacologic interventions that could be used are proper positioning of the patient, stabilization of the fracture, elimination of any irritating stimulation, and proper positioning of the ventilator tubing to avoid traction on the AT tube, which would be very bothersome to the patient. Concerning the medication, benzodiazepine, propofols, opioids, alpha-2 agonists, ketamine, and even sometimes etomidate can be used in the ICU. Etomidate is usually avoided. Talking about benzodiazepines, it provides amnesia, hypnosis, and anxiolysis, but it doesn't give any analgesia to the patient. The most commonly used is midazolam because it has rapid onset, peaks very rapidly, and its duration is very short compared to the other benzodiazepines like diazepam or lorazepam. Propofol also provides amnesia, hypnosis, and anxiolysis without analgesia. It also has very quick onset, peaks very rapidly, and its duration is short. The dosing is a bit different depending on our goal. In case you need any, in case you need an anxiolytic dose, the dose is about 5 to 20 milligrams per kilo per minute. The dose increases in case you need a sedative hypnotic, it becomes 20 to 50 micrograms per kilo per minute. If you need an anesthetic, the dose is about 100 micrograms per kilo per minute or more. These doses very rarely used in the ICU because it makes the patient hypotensive, which we actively try to avoid. Opioids is the best drug to provide analgesia to the patient. It does not provide any amnesia or hypnosis. The most commonly used in the ICU is fentanyl. Other drugs that could be used could be dilaudid or hydromorphone, morphine, meperidine, codeine, remifentanil. Ketamine acts by stimulation of the NMDA receptors. It can be a very good drug to use in the ICU in a patient with rib fractures or who is basically has respiratory depression and is not intubated. It releases catecholamines, so it can cause tachycardia. The main advantage is that it's a bronchodilator. It may be used to treat severe acute asthma. When you combine it with benzodiazepines, it needs to be combined with benzodiazepine to reduce side effects because its side effects as bad vivid dreams can happen with higher doses of ketamine. The main problem with current sedative agents are that they have prolonged weaning. They cause respiratory depression, can cause hypertension. Some of them can also cause tolerance, hyperlipidemia, increased infection, constipation, and lack of orientation and cooperation. Alpha-2 agonists are another class of drugs that can be used. Those drugs can actually provide amnesia, hypnosis, anxiolysis, and also a small level of analgesia. The alpha-2 receptors are basically in the brain, the locus coeruleus, in the spinal cord, and the peripheral vasculature. And this is why these drugs, the alpha-2 agonists, have all those effects together. Dexmedetomidine is the drug that's most commonly used in the ICU. The alpha-2 agonist is most commonly used. The loading infusion can be started from at 0.25 to 1 milligram per kilo. It takes about 10 to 20 minutes to actually have an effect. The maintenance infusion can be 0.2 to 0.7 microgram per kilo per hour, and sometimes it can even go to as high as 1.5 microgram per kilo per hour. Dexmedetomidine or Precedex is a selective alpha-2 receptor agonist. It's a sedative, it has analgesic opioid-sparing properties, and it has sympatholytic properties. The onset of sedation is within 15 minutes, and its peak action within 1 hour after starting the infusion. It has rapid redistribution into peripheral tissues and is metabolized by the liver. The most common side effects are hypotension and bradycardia. The main advantage of dexmedetomidine or Precedex is that it does not significantly affect respiratory drive. It's safer for use in non-intubated patients. However, it can cause loss of oropharyngeal muscle tone, hence need to watch for any airway obstruction in those patients. It also reduces the need for opioids. The most common mix used in the ICU is an opioid, usually fentanyl, mixed or with another infusion like midazolam or propofol to provide the amnesia, the anxiolysis, and hypnosis. Other drugs can be used also like alpha-2 agonist and propofol, so Precedex and propofol, the Precedex providing the analgesia if the patient does not need opioids, or as well as Precedex and benzodiazepines. Precedex can also be used with morphine or fentanyl. Now, how do we monitor the sedation of a patient in the ICU and its level of analgesia? The most commonly used sedation scoring scale is the Richmond Agitation Sedation Scale. There are other scoring scales as the Ramsey Sedation Scale, the Sedation and Agitation Scale, and other ones that are very rarely used. Now, the RASS scores. So the Richmond Agitation Sedation Scale is the most commonly used scale to assess the sedation in ICU patient. For a scale of 0, for a score of 0, the patient is alert and calm, and the more negative it is, the patient is more sedated, and the higher the score it goes until 4, the more excited, combative the patient is. Why are the scales very important? They provide a semi-quantitative score. They standardize the treatment endpoint, so for example, if you need to titrate the fentanyl or the propofol to a RASS scale of -1, it's easier for the nurse to actually assess the sedation of the patient. It reviews the efficacy of sedation, it facilitates sedation studies, and it helps to avoid oversedation. What they don't do is mainly assess the anxiety or assess the pain. They can't help us in a paralyzed patient or predict any outcome of the patient. And then this is why it's very important to reassess the patient all the time. Sedation score should be an endpoint. We should initiate sedation slowly to a desired endpoint to avoid oversedation. And the infusion rate should be periodically titrated down until the patient begins to emerge. In case the patient becomes undersedated, the increase in infusion rate can be increased. The infusion rate can be increased again. What are the advantages of those scores? Studies have shown that the use of those scores are associated with decreased use of sedatives, shorter ICUs and hospital lengths of stay, shorter stay on the vent, less delirium, less cognitive dysfunction, and lighter level of sedation, which are better than deeper levels. Neuromuscular blockade in the adult ICU. It's used most often acutely to facilitate intubation or selected procedures, but it can also be used as an actual infusion, especially in ARDS. The main indications are to facilitate mechanical ventilation in patients with, as we said, abdominal compartment syndrome, high airway pressures, or dysynchrony. It can assist control of elevated intracranial pressures, can reduce oxygen consumption, it can prevent muscle spasm in neuroleptic patient syndrome, and it protects surgical wounds or mechanical device placement. What are the issues? The main issues is there's no analgesic or sedative properties. It's very, very important to have a patient sedated before giving any type of paralysis. It's not to be used without the ability to establish or maintain definitive airway, and if it's administered for a prolonged period, we need to use an objective monitor to assess the degree of paralysis, like the train of 4. Succinylcholine is a very used paralytic in the ICU, especially for intubation. To note that it increases serum potassium level by 0.5 to 1, most usually 0.5. It can cause bradycardia, anaphylaxis, and muscle pain. It can potentially increases intragastric, intraocular, and intracranial pressure, and it severely elevates potassium due to proliferation of extrajunctional receptors in patients with denervation injury, stroke, trauma, or burns of more than 24 hours. These are the paralytics that are most commonly used: succinylcholine, rocuronium. The infusions, the most common used is cisatracurium or Nimbex, and vicuronium are usually used in the ICU. Train of 4 is the method of choice to monitor the degree of paralysis of a patient. As a take-home message, sedation, analgesia, and paralytics are not a treatment, it's just an adjunctive therapy. Never use paralytics without sedation and analgesia. The same way, never use sedation without analgesia. Analgesia should always be first. And last, monitor about under and over sedation. Monitor the pain score. Sedation should be daily interrupted to assess the level of awakening of a patient, and a target sedation score has to be decided.